you know what I love about what you're doing? You're taking the bread and butter and getting granular with it. Taking very simple conversations about cracks, voids, lack of ideal marginal adaptation. These are things that clinicians go into their entire career without ever noodling over. I was sharing with a dentist today a concept that I love analogies, and I think this analogy bodes well, and it dovetails very nicely with where Christian's at with his Instagram page. As clinicians, it's our responsibility to reflect on the work that we do. But we know that there are some clinicians out there that aren't really taking a look at what they're doing. And I'll be the first to admit that there are points in my career where I didn't necessarily look in the rear view mirror. So here's the analogy. You're driving down the road. If you never looked in the rear view mirror, you might not know that you have an oil leak. And if you have an oil leak and you're unaware of it, at some point you're going to crash. But if you're looking in the rear view mirror, you might actually see the oil leak soon enough to be able to stop, slow down, and adjust. And I think it's those micro adjustments that make us much better clinicians. And I think what Christian's doing is not only providing the world what he's, the beautiful work that he does, but he's self-reflecting on himself. If he wasn't self-reflecting, he wouldn't take the time to use photography. Dr. Hicks, who's on here, photographs a lot of his work. When you photograph your work, you're looking in the rearview mirror. We've all heard about the value of CAD/CAM dentistry. I'm not going to talk about milling and marginal adaptation and things like that. But what that technology has done for us, it provides us an opportunity to look at our preps under a microscope, a digital microscope of sorts. So, Christian, I applaud you with what you're doing. We're always toting the line of, am I being conceited by sharing what I have? The answer is no. If somebody's going to look at your Instagram page, it's because they want to see it. So let that light shine. I'm becoming your number one Instagram advocate, and others that are out there through this Nikkei venue, I advocate that we share our work, and not there ever be a moment where person ABC is trying to show off. This is a safe place to do that. Likewise, we should share our mistakes, so we learn through each other's failures. And I'll be the first to share many of my failures. As a matter of fact, much of the comments that I make come from a world of where things didn't go well. There's a saying that we use in the office often, which is, experience is what you get when things don't go as you planned. So it's okay to share those failures with each other. So Christian, your Instagram thing is great. Keep it going. I'm learning a lot as we move forward. I also think you have an air of humility in that page, which is refreshing too. Where Facebook is replete with lots of, perfect cases, it's nice to see a little bit of less than perfect cases peppered in there. Very well. So we have a good group tonight. I wanted to take a step back, maybe not talk so much about treatment planning, but something maybe that borders on the line of philosophical, but has a heavy clinical relevance to it. And it's the question of what comprehensive dentistry truly is. I think when we all graduate dental school, we have the perception, maybe we can call it a misperception, that we are all comprehensive dentists. And I can't speak for others, but when I graduated dental school and even when I finished my residency, I was very far from whatever that term actually means. To me, that's a journey. It's a journey at which never truly ends. To be truly comprehensive is really never a destination, but it's a journey. And I just want to share some ideas on what do we think comprehensive dentistry truly is. And my hope at the end of this hour is that we maybe convert ourselves away from being single tooth dentists, where we go in, do a hygiene exam, and just because the patient doesn't necessarily have rampant decay, we don't fall into the trap of saying everything looks good. That's the emotional way to get through a hygiene exam as fast as possible, where we use that phrase because we don't have the time, energy, or maybe the experience and knowledge to actually dissect what's truly going on in the patient's mouth. We have a friend slash mentor of mine, Dan Armstrong, who's here. I had asked him to be on. I consider him one of my closest colleagues, but more importantly, a mentor, somebody who I look up to immensely. A lot of my concepts, which may seem brilliant, are actually just regurgitations of something that he said once upon a time. So Dan, thank you for being here. Dan was a longtime SPEAR faculty member for the, he did a lot of the facially generated treatment planning stuff. But Dan, for all intents and purposes, is a comprehensive dentist. You know, he's the dentist that we aim to be. So I can't wait to see what he has to say and what he can share. And I look forward to having an active dialogue with him. But before we do that, I'm going to go ahead and share my screen. I wanted to go over a few of the concepts that we've gone over recently, but in an effort to be redundant by design, I thought it would be valuable to actually go over some concepts that a few of you guys have come back front and center and said, Nick, I don't know what you meant by that. So here I am going to go over this. I'm going to let a few more people in. So title of tonight's discussion. This isn't a lecture. None of these are ever lectures. These are discussions, talking points. But what constitutes comprehensive dentistry? I just wanted to share these two pictures I put up when I got home tonight. On my way home from a friend's practice who's going through some tough times, I was there helping out. I had the beautiful opportunity of nature showing me a very bright full moon or close to full moon on one side of the sky with a very beautiful sunset on the other side. And if you don't take time to appreciate when nature sends these things your way, I advocate for that. So I just wanted to put that at the introductory part of my presentation tonight. So if you'd like a free CEU, which is PACE approved through NECAID, please keep your camera on. That's not a requirement, but it is a requirement if you want the CEU. And Julie is here to collect the presence of certain people that are interested in this. Otherwise, feel free to hang out in the digital shadows, and if you'd like to use the comment tool for questions or thoughts, feel free to type away. As always, this is a time to share ideas. I'm a student as much as I am trying to be something of a teacher here. So this isn't about dogma. The more we share, the more we expose to the more that we are exposed to new ideas, the better we get to serve our patients. So this is not about right or wrong answers. It's just pure collaboration, collegiality. I promise there's going to be things I'm going to say that maybe are wrong, at least wrong in some people's eyes. But I firmly believe if we have these discussions, that we're going to end up more valuable for our patients as time goes on. So let me switch over to the screen here. Update on recent sessions. So this morning I had a meeting with a local ENT, something that many of you guys know has been a long time journey, trying to find an ENT that one understands the challenges of what we're trying to solve in the world of dentistry. But more importantly, willing to actually talk to a dentist. So I had a fabulous opportunity to talk to one this morning. There'll be a lot more with her as time goes on. But I had a question that came up recently from the doctors. Nick, why are you so interested in this nasal breathing thing? I understand it's important, but how does it affect dentistry? In a nutshell, I'm not going to spend much time on this, but I think it's relevant for us to resurface these concepts as time goes on. How does poor nasal breathing affect the teeth? This is the simple 10,000-foot view way of viewing it. We know in the ENT literature, it's very clear that poor nasal breathing through lack of nitric oxide uptake into the lung increases sympathetic tonality. Sympathetic, parasympathetic nervous system activity. Sympathetic is our fight or flight state. So when we're in that state, we're more likely to have heightened muscle activity. We know in the literature that when we have increased sympathetic tonality, that the muscles, specifically the masseter and the temporalis and other muscles, are just in a heightened state. When muscles are in a heightened state, you're more likely to have tooth problems. So this is the 10,000-foot view. I'm going to come back to the slide. As we always try to bring in the airway component into what we talk about, I thought this was a simplified version of trying to articulate what that connection is. So that one's for you, person who shared that question with me last week. Another one was really getting back to this idea of platform switching. Yes, I'm bouncing around from airway to platform switching, but I thought of an analogy earlier today. Our patients don't come with a subject matter, they come with all of the potential problems that we see in dentistry on a day to day basis. So, switching around to me, being able to pivot is really what makes us great clinicians. But this question was asked, so I thought it was important to share with everybody, even though we just went over this. Platform switching is essentially the concept of changing the diameter of the prosthetic platform in relation to the implant. So this is what we call a non-platform switch situation, where the abutment is of the same external diameter as the external diameter of the head of the implant. In other words, the gap, the micro gap that exists between the two, lives close to the hard and soft tissues that live outside the implant. The concept of platform switching, which came out in the last few decades, moves the micro gap internally, away from the hard and soft tissues. That's been shown clinically and scientifically to decrease marginal bone loss around implants. So when we talk about platform switching, essentially we're talking about using specific implant systems and specific prosthetics that allow us to take the micro gap and move it internally. Some implant systems, such as this one here, this was just an image I pulled off the internet, not to advocate for this particular implant itself, but this particular system has one platform size with many different implant widths. So looking from a coronal perspective, you can see that the width of the implant gets wider and wider as time goes on, as the diameter increases, thereby taking the micro gap and moving it towards the center of the implant. So that's the idea of platform switching. I think it's important. If you're a restorative dentist, you need to understand this. This is not necessarily a surgical concept. It's actually much more of a prosthetic or restorative concept. So when you hear platform switch, do know as a restorative dentist, this is something that you should understand. If you have any questions, I'd be happy to dive into this more. This was a really nice picture that talked about the micro gap. What's in the micro gap? Bacteria. No matter how good the fit is, there's always bacteria there. This is a platform switch situation because the prosthetic components are not sitting at the same outer diameter as the implant itself, as we see here. So this is a much more unfavorable situation. You're more likely to have bone dieback as a result. Here in the platform switch, the bacterial leakage tends to stay farther away from the bone, and this has been shown to be more favorable. Anybody have any questions on this, only because it's come up many times? Does this make sense conceptually? For those of you that are out there, it might be good to have a conversation with your surgeon, if you're not placing the implants yourself, to see what implants they place that are able to be platform switched. I would say in today's day and age, most implant companies are at a point where the platform switching is part of every implant system, but you really have to know how to ask these questions in order to understand what you're using. All right, pivot number 3. Luke Libby, one of our partners in Buxton, is taking this course. He had agreed to sharing his experience. This is for those of you who might be interested in doing advanced orthodontics, this is above and beyond Invisalign. This is actual bracket and wire orthodontics. This is a great program that has a great track record down in Connecticut. Luke, do you want to share your experiences so far? You're in your second year so far with the program. I believe it's a 2-year program. Would you like to shed some light on it?
Yep. You guys hear me okay?
Yep.
Okay. Oh yeah, program essentially, well, obviously, as the name insinuates, it's international. So I just am part of the international thing as a whole, but I go to the courses in New England for that group. It's held in Connecticut, like Dr. Wood mentioned, at a hotel at the Bradley Airport, and we meet 4 times a year, and they have advanced seminars as well that are available for anyone to go to. But essentially, there's a lot of focus on growth and development. So there's definitely it's geared toward treating early, finding airway problems in kids and adults, but especially in kids, because obviously, like I'm sure many of you know or have heard or seen, if we can correct the growth patterns early on, or help guide people to grow better, then they just don't have all these problems later. They don't break their teeth. They're not cracking things. They don't have major recession. They're able to take care of their teeth, and we can get them there. There's a lot of cool different techniques that you learn as a result. Some of the stuff we do, some of the guys or women who are part of the course, they do a lot of either just Invisalign. Some people do just wire and brackets, and I've kind of tried to take that and learn how to do combination of cases for people at our office, or one or the other. But the nice thing is, if you're someone who just does Invisalign or only wants to do Invisalign, you can still take all of the force mechanics that you learn from bracket wire and apply it to Invisalign. And it makes it so when we're looking at all these big cases, we're trying to solve the problem of, okay, this person came in, their teeth are all broken, cracked, they're crooked, frostbite, what have you. And we can take it, and you're going at this with a more complete picture on how to solve their problem, because you're seeing more of the problems they have.
Great. Hey, Luke, how much time do you guys spend on phase one ortho, interceptive orthodontics? I think you answered the question, but
Yeah, it's the heavy,
craniofacial development.
the heavy phase one for sure.
Great. Yeah, we we did a talk, I believe, 2 months ago on asking the question, if we're doing so many mandibular advancement devices to treat OSA, what could have been done prior to that? Well, if you have a 60-year-old who is having a hard time breathing at night because there's not enough room in their palatal vault, it's easy to say what could have been done when they were younger, and that's really where concepts like this come in. So, Luke and I talked a year and a half or two ago, and there's a few other the doctors that are here tonight. We've had a lot of talks about craniofacial development. It's not that we necessarily need to do this. I mean, we really need to incorporate the pediatric dentists, the orthodontists, at least the orthodontics that are, well equipped to be able to provide these services for their patients, and not make the recommendation of waiting till they're 12 to 13 before doing phase two, and only phase two. But if we're well versed in this arena, we're just going to see it more, and therefore we're more likely to help the patients, whether we are doing the execution or not. I feel very blessed that Luke is acquiring this skill set, because it's not one that I have. But it's so damn important, especially as I start to see my kids grow, and I'm already starting to see issues in their craniofacial development. As a parent, I want to make sure that we are providers that provide the level of care I would expect in my own kid. And Luke, I'm super proud of what you've done. It's been a commitment, both financially and time-wise, but it seems to be paying off. You were able to see my nephew today, and I have no doubt you're going to be able to change his life. My nephew has that prototypical poor nasal breathing, mouth breather, bags under his eyes, ADD. The very typical story that we hear young adolescents have when they don't have enough craniofacial development. I can't wait to see what you can do, Luke.
Hey, Doc.
Yeah, Dr. Hicks.
Just to kind of bridge off of what Luke's doing. I know it sounds like there's a huge emphasis on early interceptive orthodontics. Luke, would you say that there's adequate time spent on solutions for the patients that most of us see in a general practice, adults that are destroying their dentition and are seeking orthodontics, not just for straight teeth, but also to try and fix the underlying problems themselves?
You mean from the course's perspective?
Yeah.
I mean, it's definitely brought up. Maybe not as much. There's definitely it's a very heavy focus on the early handling of these cases. But honestly, if I brought a case like the people we see, like probably 80% of the time anyway at our office, or whatever everybody else probably sees, someone who's been living with what they've been living with for years, if I bring that to them, they have no trouble handling it and working on cases with me if I show them something that's like that. it's all the concepts are all essentially the same. And what's kind of nice, I Dr. always brought up in one of the previous lectures, I don't remember offhand, but we can expand in adults. Bottom line, it used to be thought you couldn't expand adults. There is a way to do it that works and doesn't push teeth through the alveolar housing. There's ways we can achieve growth and development in kids, and ways we can help guide some of that growth and development that didn't happen even when people are adults to try and make the conditions better. We just have to get creative and make it happen.
Cool.
Beautiful. Yeah, Luke, to follow up on that expansion comment, expanding adults without surgery. So we have SARPI and MARPI, which are surgical techniques to expand the adult. The conversation's always been, when does the suture actually fuse or close off? In reality, when you expand the right way using removable appliances in adults, you actually get alveolar expansion or transverse alveolar width without actually opening up the suture 100%. I've done it on myself. We've done it with many patients. So when we increase the transverse expansion, we see some of that expressed through diastema creation, which tells us we are opening the suture to some degree. Again, these are in adults, which is harder to do. But we have found techniques and methods and science that supports us in doing that, and we've been very successful in that arena. In my study club, the oral surgeon swears that I'm smoking crack or doing whatever, and I don't know what to tell him other than we have CAT scans that show we're not moving the teeth out of the alveolar housings. It's very well documented in the literature. It's just newer technology, newer age ways of treating patients. But like you said, the best way to treat those adult patients is to treat them when they're young, so you don't have to intervene at an older age. Yeah. Thank you, Luke, for sharing that. I thought this was useful. It's a very good group. They've been around for a long time, and any general dentist I know that's gone through this has had great things to say about it. Well, we talked about this case last time. We looked at a cross-sectional image of an implant with potential bone loss on the facial. The reason I put this back up here, we were talking about cement versus screw-retained, access, channel angle, so on and so forth. But somebody had asked me the question about guidance, so I wanted to bring that one back up. Shallow versus steep guidance is a concept that is rather commonplace in the world of Spear, Pankey, Kois, so on and so forth. When you're doing dentistry, it's good to understand what this concept truly means. And Dan Armstrong here could probably talk for days on this particular concept, but anytime somebody asks me a question after we have a conversation, I think it's valuable to bring this back up. So I would encourage everybody to understand what this concept of shallow versus steep guidance means. Why is it relevant when you have implants versus natural teeth? When is it relevant when you're talking about designing occlusal schemes to create different sort of protrusive guidances, so on and so forth? This stuff matters. When you're doing single tooth dentistry, does it matter? Yes, but not as much as when you're doing full mouth dentistry. And we're always doing full mouth dentistry in some capacity or another. So these are important concepts. So I'd be happy to revisit this at some point. This was the treatment plan we went over last time. I'm going to skip that one for now. I'll come back if we have time. Chad, if you're okay, I'd like for you to share your experience. So this was a case that Chad is working on where he did some socket preservation between these two lower left prepared teeth. And he was having trouble, despite what I would consider very good preps. He was having trouble getting the temporaries to stay, and we had tried several different methods. Ultimately, what he ended up doing was adding to the facial a 17, and then reprepping the lingual to increase the path of draw and increasing a couple of retentive grooves. Hey, Luke, you want to hit mute? There we go. Thank you. So the idea here was to increase retention through a more ideal path of draw. Chad, do you want to share your experience with the increase in retention on this case based on what we had discussed?
Yeah, sure. So it worked and it didn't work at the same time. I added the composite to the buckle of 17, although I was kind of limited in how much I could do just because of the PMMA bridge. I would prep through it essentially to relieve the space for the new composite, but that helped a little bit. The grooves I think definitely helped, and then I relined it with Fluxitemp, and it seemed like what happened was that it actually raised the occlusion a little bit when I did that. So that was a whole nother issue. But as far as retention goes, it definitely helped. It was very secure without cement after I did that. And so once it hasn't come off since I've done that. So fingers crossed, but we just had to adjust the occlusion after that because of because it raised it up a little bit. But.
Yeah. So in a nutshell, for those that weren't part of this, we spent 15 minutes talking about this last week, which I thought was very valuable when it comes to bridge preps. How do you know what your path of draw is, especially when you're this far back in the mouth? Well, fortunately, we have this technology now where we have scanning. We had talked about the concept of using an occlusal mirror so that you can look down the occlusals of both of the abutment preparations to confirm that you have a good path of draw. And Chad's been super open about letting us share this conversation with this case because it's so valuable for us to understand these are common things that happen in clinical practice, and we just don't necessarily know. So shining a light on a case like this, I think, or I know, provides value for everybody. So in a nutshell, what he had done is added composite to the buckle of 17, and then provided some more taper to the lingual part of that number 17 prep to make it better aligned with number 20. And from that allowed the material to adapt better. So there was more intaglio coming in contact with the teeth. And glad to hear it's been working well so far. So simple clinical situation. It looks like he's sharing. Is this your reline?
No, it's the reline temp, yeah.
Yep. So it looks like you put some retentive grooves in here. So it looks like you put 4. Retentive grooves are helpful. We don't want to overdo it and violate the pulp, but where we can, especially where there's restorative material, I do think retentive grooves, conservative retentive grooves definitely help. One of the challenges that I found when you put 4, if they're not perfectly axially aligned, you can lock these in. So if you're going to do 4, just keep in mind you really want to make sure that they're parallel with each other. Otherwise, you end up having another problem.
Yep.
Yeah. Thank you, Chad. All right. All right. On to the topic of the evening. I wanted to start with Peter Dawson. This isn't to advocate for the Dawson Academy. Dan and I have had conversations about all the different academies, and his comment, I think, is the most valuable way to look at it. He says they all provide value. There are certain aspects of each of these organizations that provides value, but I think what they all do well is they do a really good job of teaching us how to be comprehensive dentists, whether it's LVI, Spear, Kois, Hornbrook, all of these different academies really get us to think outside the box and not become single-tooth dentists. So I wanted to share this. This was something I had saved years ago and I had revisited a couple times, and I think this is Dr. Dawson doing a great job of articulating what we're going to talk about tonight.
Welcome to the concept of complete dentistry. I hope that doesn't scare anybody off. I hope when we talk about complete dentistry, you don't think of what I like to refer to as smell me dentistry. Look how good I am, look what I do, I'll show you befores and afters, all this kind of stuff. No, that's not what it's about at all. What we want to do in this seminar is to show you that...
Thank you, Chad. Let's see.
My fingers are good.
about complete dentistry, you don't think of what I like to refer to as smell me dentistry. Look how good I am, look what I do, I'll show you befores and afters, all this kind of stuff. No, that's not what it's about at all. What we want to do in this seminar is to show you that some of the most fundamental
Chad, can you hear it?
essentials are often either neglected or not understood by, I'll say this with absolute certainty, the vast majority of
Chad, can you hear it?
We find that usual and customary dentistry, as a rule, does not pay attention to some of the things that we think are most important to the dentist who wants to really do a good job of taking care of his patients or her patients on an everyday basis, everyday dentistry, from single-tooth dentistry to major, complete reconstruction. The principles become the key to whether you're putting in a single crown or whether you're taking care of a sore tooth or a hot TMJ or a headache that's related to dentistry. And what we're learning there is that the vast majority of headaches are dental problems, solvable by you in a general practice, and solvable by you predictably, and if the diagnosis is made correctly to start with. We want you to understand these things because these are the patients that are walking into your office every day, and most of them, usual and customary practices, are not even being diagnosed. And so we want to look at this concept of complete dentistry as being the opposite of incomplete dentistry. You know, it's been said that probably the most significant discovery in our generation is that we can change the entire process of what we do by changing our attitude. And I want you to think for just a minute, a little deep here, and I want you to think about what your mental picture is. How do you perceive your practice? Do you perceive it as the go-to practice in your area? Or do you perceive it as, well, I'm just I practice dentistry, I just do what everybody else does, I fill teeth. What is your perspective? Because see, if we can change a perspective, it isn't up where it should be, it changes your life. I'm not going to be satisfied if we don't change your life, because I know that that's what happens when dentists start to understand some of the things that they never understood before. So what's your mental picture of your practice? What's your mental picture of your life as a dentist? I see so many dentists and talk to so many dentists who say, oh, I'm stressed out, I wouldn't even go to dentistry today if I had it to do over again. You know, the way I see dentistry, I see it as the most exciting hobby in the world. And if you can't get excited about dentistry and love to go to the office and do what we can do on an everyday basis, then there's something missing in what you know about dentistry. And whatever that is that's missing can be learned. We can fill that void. And that's what we want to do. What's your mental picture of your reputation? Do you feel that your reputation as a dentist is, I'm just a dentist, or am I the best dentist in my area? I think it's worthwhile to try to be the best dentist in your area. It changes everything. It changes your income, but it changes more than that. It changes your happiness. It changes your satisfaction, your contentment of what you do. And so let's look at that in regards to your future, and let's pin down a couple of those perceptions that we see so often. Do you see yourself as a tooth dentist? So many dentists do. I've heard dentists refer to themselves as tooth plumbers, tooth carpenters. Well, you know how I look at a tooth dentist? As somebody that just looks at teeth and doesn't see anything else around those teeth. I don't want to be a tooth dentist. Get me wrong. Don't think that we're putting down dentistry or putting down teeth. No. I think before this week's over, you're going to know we like teeth. But the teeth have to fit into a total picture of the total masticatory system. You see, we want to get this thought process going that the teeth are part of a system, and if we don't understand the system, we can't do all of the things that dentists could be doing to make teeth comfortable, stable, maintainably healthy, and, believe me, the very best aesthetics that you can possibly do come when you understand how those teeth fit into this total framework of the masticatory system. That's when we have functional harmony. And when we have functional harmony, we have anatomic harmony. That's the very best aesthetics we could get. Natural aesthetics.
All right. Thank you, Dr. Dawson. So hopefully that, that message that he just shared, Chad, you want to give me a thumbs up? Can you hear me okay? All right.
Yep.
That message that he shared resonated because it's hard when you're in dental school to understand what that truly means. And I think he did a great job of articulating what it meant. And Dan, if you can, if you're ready, I would love to know when you became a comprehensive dentist. What was your career like going from single tooth doctor to a comprehensive dentist? Go ahead and hit unmute, Dan.
I'm allowed to speak now.
Yes, you have
Hearing
the
me?
mic.
Okay. It's interesting. I went to a celebration of life a couple of weeks ago for Dr. Bob Tanner, who was an orthodontist in Portland. And I came to Portland out of dental school with another classmate and rented space from this orthodontist at 440 Western Avenue, where there was a prosthodontist and 2 oral surgeons. And that brought back memories of the orthodontist challenging me to become more of a more than just a dentist than when I graduated from Tufts. So that was where I started, I guess. And I had a general practice for years, and I took a year program at Case Western in aesthetics and got accredited in the ACD. And I took a year program and taught through the Harvard implant program for 3 years and got into the fellowship of the AID. So that was in probably after I'd been practicing 7, 8, 9 years. And it developed into where I had just a referral practice and only accepted referral patients for comprehensive care. And I had a team of other colleagues, a couple of periodontists, a couple oral surgeons, a plastic surgeon, and even a prosthodontist to help me once in a while, and lab technicians that we were able to get referrals for handling comprehensive cases. You showed Pete Dawson. I saw that lecture. I saw L.D. Pankey before he started the Pankey Institute. I saw the founder of the Academy of of Aesthetic Dentistry back in his last lecture when he was at the Academy of Aesthetic Dentistry meeting in L.A. So all of that happened after I'd been in practice probably 8 to 10 years. And so that's I realized that and it was fun for me because it wasn't just, it became a game. It became and how to put the case together and how to interact with the patient to do the right thing for them, what level they were at and where I needed to take them to the next step. So I don't know if that answers your question, but that's kind of my history there.
Yeah.
Some of those cases you presented earlier, Nick, I would have loved to comment on a few things, but later times, I guess.
Well, we'd love to have you on more regularly. And as I was going through that, I could just hear you in the background saying, "But I have something else to say." Dan, I remember bringing an articulator to one of your study clubs back in the day, and I had a question, and I remember you giving me an answer, and I'm driving home, and I'm like, "But he never answered it," and it wasn't until I realized that what you were saying was the problem was actually somewhere completely unrelated to where I was focusing, and you articulated it well. I just didn't have the understanding at the time to understand what you were saying. The concept of, say, the teeter-totter tooth, where, the first point of contact and centric relation, the centric occlusal contact, for example, sometimes shows up as problems somewhere else in the mouth. How do you resolve this unless you understand the whole system? And I think that's, why it's important to understand as much as we can about this.
like you said at the beginning, we all make mistakes, and sometimes you get a little cavalier and you think you figured it out, and sometimes there's a missing little issue that can throw you off course for the whole case, and you have to be able to keep assessing as you go through the whole case planning process. I've made a lot of major mistakes in cases that I had to go back and retreat or whatever over the years too, but I learned as I went, and it became more comfortable.
Yeah. Dan, can you speak a little bit to the diagnostic process, how the diagnostic process in your practice evolved over the years?
Well, when I gave the elective at UNE for a couple of years, I always talked about, I went back to my childhood, I guess, and I went back, Popeye the Sailor Man, and he always said, "I am what I am." And you as a provider have to know your patient. They have a problem. How did their problem get this way? Is it genetic? Is it a habit? Is it non-compliance? There's something going on that they have this problem. And I like Luke did a great comment on his training in orthodontics about growth centers and phase 1 and phase 2. We've learned so much about that in the last 20 years. So you have to know why, if someone is non-compliant, you got to count on them long-term being non-compliant. If they don't come in for follow-up, they won't come in for follow-up. They may be good for a while, but they won't long-term. So how can you work your case in understanding their issues that you can still have a successful case? Secondly, I'm trying to go through what I did. So I had Popeye. I am what I am. Know your patient, and then know when you need help. Your comprehensive care means you have a team. You have other people that you can, colleagues that you are intimately involved with. You know how their practice works. You know how they set up their cases. You know how they do their treatment. You know their healing times. You know their follow-ups. And, you can ask them, when you're not sure of how, like you're talking about platform switching. Well, if your surgeon doesn't put the implants deep enough in the beginning, you can't platform switch anything. You have to be crestal bone involved to the head of the implant, or platform switching won't work anyway. So, know what your specialists are doing, and work with them and work and learn from them and teach them. I had a number of my specialists I work with, and I saw some of this the other day. He says, "You made me a better dentist." And it wasn't that I was so smart. I just told them my problems and how they could help me to do a better job, because I knew what I expected from them. So then that seek wisdom, and and then sometimes you make a mistake. And I taught about the kiss of death, because when you get to a certain point and something isn't working, like that 4-unit bridge that who was doing it, Christian or Chad?
Chad.
Yeah, the success rate on a 4-unit bridge like that, long term at 8 to 10 years, is really low. It's either, even if you get the occlusion right and you get retentive grooves or whatever, that's a tough situation. You may need to put in a stress breaker. You certainly need axial, groove retention to hold it. You need to make sure you don't have any incline plane contacts or CR/CO discrepancies that are going to lead to lateral pressure, protrusive pressure on that, or retrusive pressure on that. That's not a long-term win-win, just the statistics prosthetically.
Just to clarify, Dan.
Yes.
It's a temporary. We're doing implants here soon in that area.
Okay, Chad, good work. Okay, so it's when you get to a certain point and something isn't working, back up, because you've seen it's going to fail. So involve the patient. Don't try to cover anything up, and go back and work it through again and try to make it right. So that's a nutshell of talking about being comprehensive.
Yeah.
And also, you really need lab technicians and you need auxiliary people. You may need a plastic surgeon. Nick, you talked to an ENT. That's wonderful. There's other medical providers that can help you with certain cases, certain little linkages in certain cases that'll really make a success of a case.
Right. Yeah, one of the times I had chatted with you, Dan, you talked about your interviewing the patient. You had made the comment that you interview the patient versus the patient interviewing you. Can you shed some light on that? Because I think it's so valuable to hear.
Well, yeah, I guess I wanted them to know what they expected of me. And I didn't want them to think that I was a healer. And I wanted to, what did they expect of me? And obviously, I want to have perfect teeth. I want to have a great smile. I want it to last forever. I don't want it to cost too much. And then I'd ask, well, if that's going to happen, this is what I expect of you. This won't work unless you do your home care, unless you show up, unless you tell me if something isn't quite right, and tell me if you're upset about something so I can, confront it. I wanted to know very upfront their feelings, and I wanted to know their expectations, and I wanted them to know mine. I wanted them to respect my time, so they show up for appointments and they're not late. And I would try to do the same. So we discussed those things. Is that what you're getting at, Nick?
Yeah.
Okay.
Ever since you had said that, it always stuck with me that it's okay to be in the driver's seat when it comes to the relationship between the provider and the patient. But I think what you're hearkening to is aligning expectations, making sure that everybody is on the same page.
Oh, I saw an old friend of mine who mentored me, Bob Sabrilli, when I came to town. He was lecturing for the seminars for occlusal studies, which was progressive occlusal analysis team back in the 70s. And so he really influenced me, and he's retired quite a while. He had diabetes and had to retire early. But he always told the story. He had this lady that he did something, and she expected him to do this, and she lost something, and he said, who do you think I am? God gave you those teeth to begin with, and I'm only a dentist. You lost that tooth and you want me to replace it. Well, I'm a dentist. I'm not God. You lost the one that God gave you. I'll do the best I can, but I'm not God. So it's nice to see him again after all those years a few weeks ago.
Yeah. Hey, Dan, a question that often comes up. When do you treat a patient who has no signs comprehensively? In other words, when are you doing mounted models to assess a patient? What are the clinical criteria where patients cross the line from they appear stable to they require a higher level of diagnosis and attention?
I guess, if you see something that's changing beyond their years, everybody's going to get a little attrition and have a little recession over years. If someone comes in and they have more wear than they should, or more mobility than they should, or they've got some joint issues, or they've got some instability somewhere, soft tissue, hard tissue, osseous, whatever, then you do it, and you point it out to them. And there are some people that have moderate wear, but they haven't changed in years, and they're pretty stable. And there are other people that get a little wear all at once. They've got some new habit that's a change, and then you need to, what's going on?
Yeah, Dawson had once talked about a concept that him and Mark Piper being an oral surgeon, that
I love Mark Piper.
world-renowned surgeon that probably knows the joint better than anybody. Kerry Bryant just got back from another Piper lecture, although Piper's retiring. I think this might have been one of his last lectures, but Peter Dawson and Mark Piper used to go for walks in the morning because they practiced in the same town. And Mark Piper being an oral surgeon that used to look at joints, and Peter Dawson being a prosthetic or restorative dentist, not looking inside the joint, but understanding and appreciating the joint. He made a comment once that always stuck with me, and it's signs precede symptoms. So
Maybe, not always. Maybe. You can get acute trauma, but yeah, if you start seeing something, signs may progress into more signs, and they may not be symptomatic too. I mean, you have a lot of patients that come in that have got moderate to marked recession or bone loss, periodontal disease. They're not. The symptoms aren't there till they have an abscess or something.
Right.
I understand what they're getting at. I do.
Yeah, not waiting for the patient to describe the problem, which would be a symptom most likely, but using our diagnostic process to look for signs. And I wholeheartedly agree with what you said. But being a comprehensive dentist often relies on us getting a picture of things on a much more microscopic level, so that we can see the problems before they actually become problems to the patient, which is what I took away from that.
Yeah.
Well,
Can I hop in on that too?
Yeah, absolutely. So Mark, by the way, Dan, Mark is a dentist joining us from Wisconsin. He's going to be coming here in the spring. He's Pankey trained, very astute, young, comprehensive dentist, and I'd love to hear what Mark has to say. He's driving right now, so you don't get to see him. But yeah, Mark.
I appreciate that.
Did you vote?
Not yet.
Oh yeah.
I know. So, for my decision tree for when I pull a patient into a comprehensive case, like if it's a new patient, I usually start that comprehensive. But for existing patients, if I'm looking around the mouth and I'm seeing, there's probably going to need more than 3 crowns over the next couple of years, it's nice to look at, hey, let's study how the teeth came together, what caused them to wear down, so that when we rebuild it, even if we might do it 1 tooth a year, we're building it in a more protected bite. The other big red flag for me is a large CR/CO discrepancy. That makes me a little more nervous, or then that turns into a comprehensive. I'm taking models to study everything.
And Mark, what are you using to determine that?
The CR/CO discrepancy?
Yes.
I usually do bilateral manipulation for that. If I'm in a clinic exam, like a hygiene check.
Yep.
If I'm doing it where I'm taking a record, I usually use a leaf gauge to help assist with that.
Great.
I guess other big thing too is like muscle splinting, if that's going on, where you're trying to tell them to go laterally and they just are really either can't, or B, that jaw is just really shaking the entire time that they're going side to side.
Yeah, jaw tremor, man, how relevant is that each and every day? I think if anything, we should always take away something. Take away that when you see somebody's jaw or tongue tremoring, there's something significant going on. That would be a great case to get some more data from. Convert that patient to a comprehensive patient.
Yeah, and I don't do it every time, and I'm starting to learn that more often than not, I wish I would have taken a step back. You just find the roadblocks or find the issues before they happen.
Right. Yeah.
And a lot of patients function very well with CR/CO discrepancy, but when you start to see wear, you start to see mobility, you start to see muscle splinting, or you start to see disc displacement, then you've got issues. So that's when you have to delve in and involve the patient and explain why you're doing what you're doing and what portends in the future if things progress.
Yeah. Thank you, Mark and Dan. Anybody else have any questions for Dan? He's a wealth of knowledge. I hope to have him on here more, but while we have him, from a 10,000-foot view, what kind of questions do you have about comprehensive dentistry for Dan?
I guess I answered them all.
When you're good, you're good. Well, Dan, thank you for chiming in. I think as conversations or topics come up that I think you can provide value, I'll reach out and, hop on anytime. We meet every Monday night. We bounce around from topic to topic, and, I like pivoting from topic to topic. I like going back over certain topics just to drive points home. The whole goal is for us to cover things that probably wouldn't necessarily show up unless we're leaning on each other.
Can I make a couple of comments about, you really need to know, you really need to know your specialists, and you really know what they do and how they do it, so you can become involved in your patient's care with them. I imagine at these study meetings, you have some of the specialists that you work with you sometimes.
I've invited a few. It hasn't lined up yet, but that is part of what we're hoping to do. Very similar to what you had.
You have, with COVID, are you giving study groups in your facility again? Sometimes?
We haven't, but several of us are part of different SPEAR study clubs, and each of the SPEAR study clubs have a specialist, as you well know.
Right. Okay.
Hey, Dan.
Yes.
How can we reach you?
You can email me at dan@fiasco.farm. Nick has it.
Yeah, I'll forward if Dan,
I gave Nick a lot of my PowerPoints. I was looking for one I had that I gave with Jerry Schumann and Steve Morse on interdisciplinary care and working with specialists. And I couldn't find it tonight, and I don't think you have it, Nick. I'll try to find it, but it's like probably an hour and a half PowerPoint or something on working with an interdisciplinary group. But you can email me, and I'll try to get back to you when I'm not on the farm.
Yeah, Dan lives in Buxton, so he's not far away. If you guys ever want him to come by, check out something, I'm sure he'd jump at the opportunity to help out. Yep.
Well, it's been a pleasure, guys. Thank you very much for your time, and I appreciate all your efforts. I had a study group for 26 years, and it was great to just interact together. And, for you, all of you, make sure you challenge Nick. And, if you have a difference of opinion or some literature that says something the other way, express your views so everything gets balanced well and you feel comfortable. All right?
Yeah. Thank you, Dan.
Thank you.
All
Thanks,
right.
Dan.
Have a good night, everybody.
Thank you.
Bye-bye.
Yeah.